Good afternoon, everyone. I'm Sydney Enland, and I'm a Policy Associate with the NCSL Health Program. On behalf of the National Conference of State Legislatures, I would like to welcome all of you to today's webinar titled New Scope of Practice Website, a Resource for Policymakers. I would like to remind participants that NCSL is a bipartisan member organization of state legislatures. NCSL advocates for the interests of states and provides policymakers with an opportunity to exchange ideas. NCSL does not advocate for specific policies, nor do we take a position on state issues. This webinar is a platform for information exchange. There will be time for Q&A at the conclusion of the presentations, and participants can ask questions at any time during the webinar. Please enter your questions in the Q&A box on the bottom left-hand side of the screen and specify which speaker you're addressing your questions to. The slides are available for download at the top of your web page. There in the kind of middle of the screen, there's a piece of paper icon with a little arrow in it. If you click on that, that will bring up the slides for download. Also, today's webinar will be recorded and will be available on the NCSL website by next week as a video archive. I will begin the presentations by giving a brief overview and introduction of health professional shortage areas and scope of practice as a strategy to address workforce shortages. I will also highlight NCSL and ASPO's new scope of practice website, scopeofpracticepolicy.org. Our second speaker today will be Senator Deb Stoholt from South Dakota, who will discuss scope of practice as a tool to improve access to care in rural areas and how the website can inform legislators and help them craft scope of practice legislation. Our next presenter will be Andy Baker-White, Senior Director for State Health Policy at the Association of State and Territorial Health Officials. He will provide an overview of scope of practice legislation from the 2017 legislative session and a few state examples. He will also explain how the website can help state health agencies and others in public health. Finally, we will hear from two representatives from the Department of Veterans Affairs, Denny Woodmansey, Program Director for PA Services, and Christine Engstrom, Director of Clinical Practice in the Office of Nursing Service. Denny will speak about changes to practice issues from the VA perspective, and Christine will talk about the new nurse practitioner rule and how it has helped access to care. So again, my name is Sydney Enland, and I've been with NCSL for just over a year, and my work focuses on scope of practice, access to care issues, and also broader workforce issues and policies. Rural and underserved communities face significant challenges with access to healthcare services. In many areas, the supply of healthcare providers cannot keep up with demand for services. A shortage or inadequate distribution of the healthcare workforce can create barriers to accessing timely and appropriate care, lead to negative health status, and create significant costs for states. More than 100 million Americans live in a health professional shortage area, or a HPSA. Health professional shortage areas are geographic areas, population groups, or facilities that are designated by the U.S. Department of Health and Human Services that have a significant need for additional healthcare resources, such as primary care, dental, and mental health care. HPSAs identify areas of the greatest unmet healthcare need so that limited resources can be prioritized and directed to those areas to assist in addressing those unmet needs. People often think of rural areas as being health professional shortage areas, but they can also be other underserved areas, even in large metropolitan cities. But many HPSAs are in rural areas, and rural communities also have higher rates of chronic and preventable conditions such as obesity, diabetes, cancer, and heart disease. Primary care health professional shortage areas are designated if there is an established shortage of primary care physicians for the population. This map shows health professional shortage areas around the country, and the lightest colors show states that have a low number of HPSAs, and the darkest colors show states that have a high number of HPSAs. And there are large areas or populations of the country that need primary care, as only currently 57% of the national need for primary care is being met. The proportion of Americans living in a health professional shortage area varies widely by state, from 1.4% in Nebraska to 57.3% in Mississippi. But in almost half of the states, it is at least 20%. and limited access to primary care services can adversely influence chronic disease, which can have huge implications for quality of life and costs to states. Demand for primary care is projected to rise over the next 5 years, due largely to population growth and aging. Currently, there are not enough practitioners to fill the gap left by retiring physicians. 11% of the nation's physicians work in rural areas, despite those rural areas having nearly 20% of the population. Physicians who practice in rural areas often serve large geographic areas that require long travel times, either for the doctor or the patient. And these areas also tend to have a shortage of hospitals and other healthcare facilities. Demographic shifts, such as the aging physician workforce and the growth of the elderly population, will increase the demand for primary care services in the coming years. So utilizing non-physician practitioners who have the appropriate training and experience and integrating them into the healthcare system can help alleviate pressures on primary care capacity and help fill the physician shortage gap. Several states have addressed their workforce shortages by examining their scope of practice requirements for non-physician practitioners, such as for nurse practitioners and physician assistants. Scope of practice describes the procedures, actions, and processes that a healthcare professional is permitted to undertake in keeping with the terms of his or her professional license. Scope of practice is important because it defines the roles of providers in a state's health system. State legislators try to balance between extending the use of health professionals to fill in for shortage gaps and ensuring they are able to perform their duties safely, appropriately, and have the proper training and experience. Clearly defining these roles also allows health professionals to provide high-quality care efficiently. Some states are currently looking at their scope of practice laws for a range of non-physician health professionals. Nurse practitioners and physician assistants are often relied upon in rural and underserved communities to make up for physician shortages. Changes in scope of practice policies are increasingly used to address these provider shortages by allowing non-physician practitioners to provide care and services with varying degrees of oversight. Since each state has its own specific laws and regulations regarding the responsibilities of these providers, the range of services performed varies from state to state. State legislatures consider many aspects of a healthcare professional's practice. These include prescribing privileges, physician oversight requirements, and practice site requirements. NCSL provides the scope of practice landscape across the states for legislators to help inform them about the issues and various policy options. We do not advocate for specific scope of practice policies, and we realize that there are many viewpoints concerning scope of practice issues and that the issues can be contentious. And we also realize there are patient safety issues to balance as well as expanding access to care. This website was designed by NCSL in partnership with the Association of State and Territorial Health Officials. It was designed to provide policymakers and health officials with a tool to explore the range of scope of practice policies around the country related to improving access. This is a resource about scope of practice issues for nurse practitioners, physician assistants, dental hygienists, and dental therapists. The site includes 11 interactive policy maps, a legislation database, and case studies in scope of practice policy. So I'll briefly walk you through a few pages of the website to give you an idea of what is featured. The scope of practice policy.org homepage gives a broad overview of what you will find on the site, as well as an interactive map that will take you to each state policy page. The top bar also links you to the practitioner pages, the legislative database, additional scope of practice resources, state case studies, and our blog. Not shown in this screenshot, but at the bottom of the homepage, are links to our Facebook and LinkedIn pages, so be sure to follow us for updates. As I mentioned previously, our site tracks scope of practice policies for nurse practitioners, physician assistants, dental hygienists, and dental therapists. Each practitioner page features an overview of the provider and an overview of the 3 policy areas that are the focus of the 3 maps on the right-hand side of the page. As you can see for nurse practitioners, the policy areas tracked are practice authority, prescriptive authority, and nurse practitioners as a primary care provider. Currently, about half the states require nurse practitioners to practice with physician oversight. Other states have tried to address their access to care issues by allowing nurse practitioners to practice independently so they can reach those most rural populations. The policies for physician assistants that are tracked are supervision requirements, prescriptive authority, and scope of practice determination, whether it's determined at the practice level or by the state medical board. We're also seeing states looking at adaptive collaboration requirements between a physician and physician assistants, including whether physicians must be on site where the physician assistant is practicing. We have also seen states changing their policies on whether the details of a physician assistant scope of practice can be decided at the practice level. The providers we track for oral health are dental hygienists and dental therapists. Currently, 39 states allow dental hygienists to have direct access, which means they can practice outside the dental office in certain settings, such as schools or nursing homes, without the direct supervision of a dentist. Some states require dental hygienists to practice with a collaborative agreement with a supervising dentist. Other states do not require supervision by a dentist when dental hygienists are practicing in direct access settings. 5 states currently allow the practice of dental therapists or dental health aid therapists. They provide preventative and restorative dental care under some level of supervision by a dentist. This slide is an example of what each state profile page looks like. It includes an overview of the scope of practice policies for the featured practitioners in the state, tracked legislation, and statute links to specific scope of practice laws and regulations. This state page currently shows the laws and regulations for Colorado's physician assistants. To the laws for the other providers, you would simply click on the arrow next to the provider and the accordion will open. State policy pages are accessible from any of the maps on the website, including the map on the home page and the maps on the practitioner pages. Our legislative database allows you to search by practitioner, state, disposition, keyword, bill, session year, author, or a combination of these. In the 2015-2016 session, we tracked 135 bills related to nurse practitioners, physician assistants, dental hygienists, and dental therapists. Currently, the database has tracked 121 bills for the 2017 legislative session. States introduced many bills related to scope of practice during their sessions. The bills tracked in this database relate only to the tracked policy areas for the individual practitioners featured on this site. The resources page allows you to view additional resources for each provider type, maps of health professional shortage areas, links to professional organizations such as the American Dental Hygienists Association and the American Academy of Physician Assistants, and also state and federal resources. All resources are categorized, and in the bottom right corner, the most recent published resource is shown at the top. So to wrap up, examining scope of practice policies is one trend we at NCSL are hearing that states are considering to address workforce shortages and access to care. Again, NCSL does not take any positions related to scope of practice issues. We are presenting the trends we are seeing around the country, and we also track what states are doing regarding scope of practice policies. Please check out our website for additional scope of practice state policies and resources. Our next presenter is Senator Deb Soholt from South Dakota. Senator Soholt represents District 14, which includes Sioux Falls. She is the chair of the Senate Health and Human Services Committee and is a member of the Agriculture and Natural Resources Committee and the Education Committee. She is also a registered nurse and the Director of Women's Health at Avera McKinnon. Senator Soholt, I'll turn it over to you. Senator Soholt, are you on mute?
I am sorry, I was on mute.
Okay.
I apologize to the group. As you saw my slides go forward, you wonder what happened, right? Well, I'm glad to be with all of you and to speak about a bill that we did related to a scope of practice barrier in the state of South Dakota and how we would care about our people, which was Senate Bill 61. And we were successful with this bill in the legislative session, and I want to tell you about the act to revise and update certain provisions in the regulation of certified nurse practitioners and also certified nurse midwives. We were attempting not only to remove a practice barrier, but also to modernize our Practice Act in relationship to the national consensus model for the practice of these two categories of APRNs, to put them in a position for future models of healthcare delivery, such as telehealth services and being able to work across state lines. What our bill essentially did, the nuts and bolts, was uncoupling the CNP and CNM license to practice from a collaborative agreement that had been in place since 1979. And that would be except for newly licensed CNPs and CNMs, and I'll talk about that in a moment. And it also was a bill that is aligning South Dakota with our region. So we saw this as an access issue for our patients in our state, the demonstrated quality to be able to take care of our citizens, and also a recruitment and retention bill that we really needed to take care of with all the transformation that's going on in healthcare. As you can see in South Dakota, we really had become an island in relationship to the states around us that were not requiring supervision or a collaborative agreement. You can see in Nebraska that a supervision or collaborative agreement was in place for nurse midwives only, but in this last session, I'm not quite certain if they were successful, but they were working to remove that barrier as well. And so South Dakota had a restrictive supervision collaborative agreement that has been required for a long time. Originally, when it was implemented in 1979, it was, the language was supervision, and it was in the early 90s that it changed to collaboration. And that collaborative agreement required that one physician could only have up to 4 FTEs of collaborating nurses, nurse practitioners, nurse midwives. And we were seeing many, many barriers in the state of South Dakota, particularly in our rural areas. Let me give you an example of a small town called Oral, South Dakota, where there was a thriving practice of nurse practitioners and nurse midwives, and the physician, for whatever reason, did not comply with the necessary paperwork, and his license was put on hold for a while. So the entire clinic had to shut down because the collaborating physician was not able to practice. They then scrambled and found another physician that was about 250 miles away that had nothing to do with family medicine or with nurse midwifery. So also over time, as the nurse practitioners and nurse midwives have become more successful, they're referring out beyond their scope of practice to whatever provider makes the most sense. So even if their collaborating agreement may be family medicine, but this person needs a neurologist, they're going to refer to a neurologist. So it really became an exercise of paperwork, trying to manage FTEs versus something that was true quality. You can see that in South Dakota that we have for our primary medical care in 2017, you can see just highlighted all of the shortage areas geographically and also economically. So from a primary care perspective, we're going to need everything that we can get to try to take care of our people. You could also see our mental health care shortage areas. And this became especially poignant when we've done a lot of juvenile justice reform and adult justice reform and the mental health issues that go along with that, and we're doing more community-based services. And additionally, our College of Nursing that was trying to hire a faculty to teach psychiatric mental health nurse practitioners within our large university, they had a candidate. They did a national search, and it was of mutual benefit. And at the end of the day, the candidate declined because of needing to have a collaborative agreement and having to tie their license to another professional in order to be in South Dakota. So that just exacerbates the shortage area. Also, what was interesting politically is that right after the first of the year before session started, all of the legislators received a letter from the South Dakota Association of Healthcare Organizations jointly with the South Dakota State Medical Association, and they specifically talked about the workforce shortage that was happening, that roughly 45% of our practicing physicians in South Dakota are older than 50. And 1 in 4 residents live in primary care shortage areas, and nearly 2 out of 3 providers have lost direct care workers to jobs outside of healthcare. So they were even supporting our position that we really needed to be able to provide primary access to our citizens out into the hinterland with nurse practitioners and nurse midwives. And you can see that it became important to look at, are they working out in those areas already? And the answer is yes. So if you look in the northwest part of our state, you can see the very disparate, it's low population areas, but you can see where the nurse practitioners are working and providing care in the southern part of our state. And also when you look at the nurse midwives, we don't have very many nurse midwives in the state of South Dakota, so we're really talking about 844 nurse practitioners and only 39 nurse midwives in relationship to our legislation. So what happened? Well, it was an interesting session. I think what we really wanted to strive to do, and I think we were very successful, was to build a coalition. The House of Nursing really came together, practice, education, and regulation, to work on this legislation. We worked on it for 8 months prior to even beginning the legislative session. We didn't want to catch anyone by surprise. We have 3 major health systems within our state, and I work in one of them. And in the system that I'm in, about 1/3 of the primary care workforce now is nurse practitioners or physician assistants. So, and that is the same for the other health systems. So it was important for us to get them to political neutrality. We didn't ask them to support the bill, but we also didn't want them to come out as opponents. And that ended up being somewhat tricky during the legislative session, but we were ultimately successful with that strategy. We also built an enormous coalition of people that supported this work. One in particular that was extremely helpful was the Rural Health Network Coalition, especially for up in the Northwest. They said, we would love to hire physicians, but we can't get them to come here. And it's unfair to our citizens to not have some primary care access that has been proven in quality. We also prepared every argument that we could think of that might come up in relationship to quality. And we're very clear about what this bill was not. And it was not about making them independent healthcare providers. And that kept coming up again and again. And I think that's key to any legislative strategy, because no one works in isolation. This was merely uncoupling the licensure, and that if they worked in isolation, didn't refer when it was appropriate, then they would be held accountable within their own licensure and their malpractice support that they have. We said to our physician colleague friends, really, you should not want that liability within your practice when we're referring where we need to refer in relationship to what the patient needs, and that has been proven in quality and outcome. It also did not replace or alter any kind of practice system. So organizations, they can do what they want to do within credentialing. So for instance, a clinic I run with nurse practitioners in my real life, actually we have a medical director for that clinic, and that is mandated within the credentialing process. This was merely about licensure for recruitment and retention. And so we had to do a lot of explaining in relationship to that. We could also see that we were at a definite disadvantage. We had nurse practitioners and nurse midwives ready to leave our state because of the licensure. We had some negotiating pieces that we held out. One was for newly licensed nurse practitioners, because we met with all the physician groups prior to even introducing the bill. We didn't want anyone to be surprised. And one of the things they were concerned about was having some oversight for new practitioners and midwives that would come into the field. We agreed with that, and so put in a requirement of 1,040 hours of direct collaborative arrangement with a doctor or a seasoned nurse practitioner or nurse midwife, depending on what their role was, so that we could assure safety, working with the Board of Nursing in should they then move forward, and if it needed to be extended because that quality hadn't been demonstrated, then we could do that on an individual basis. Other states around us, such as Minnesota, has 2080 hours or one full year of full-time. Nebraska has 2,000, and the other states around us, Wyoming, Montana, North Dakota, they have nothing, nor does Iowa. Iowa never has had that requirement. So we were challenged on that point, why wasn't it more hours? And we were willing to actually negotiate that with our medicine colleagues, and they never came and asked for that to be done. Their goal was really just to have the bill be unsuccessful outright in its current format. So we were even willing to have physicians come onto an advisory board in relationship to advanced practice, not to sit on the Board of Nursing and regulate the licensure, but to be on an advanced practice advisory board to help to assure the quality and standards, and that was also a piece that was not negotiated. I'm going to, just say a shout out. We're going to hear from the VA, but that was also a helpful strategy in that in 2015 there were changes to staffing in relationship to the Veterans Affairs structures, and that helped to support our legislation as well, because of saying that we wanted to remove the barriers of licensure that did not exist within those federal agencies within the state of South Dakota. And also it's helpful to talk about our veterans and how we would care for our veterans. And we had a story of a nurse practitioner from Minnesota that was coming over to South Dakota to help move through the primary care assessments of many of our veterans that had been backlogged. And she has no collaborative agreement in Minnesota and was told to find a collaborating physician in South Dakota to meet our law, and then no longer provided that service. So it was important to have a well-rounded strategy of how we would respond to all of the opposition. The bill actually came out of the Senate without a single no vote. went over to the House. We dropped it fast to kind of catch people a little bit flat-footed. That was a strategy that I wanted to employ, and got the bill assigned to my committee that I chair so we could move it quickly. And then we had arranged with the chair of Health and Human Services on the House side to hear our bill when it was Nurses Day at the legislature. If we could move it through the Senate fast enough and get it crossed over, that it would be heard on a day when there could be 100 nurses in the committee room, which is exactly what happened, which was helpful in moving that forward out of committee, where we started to meet much more controversy, because then the opposition position really started to gain some steam. At the end of the day, after a lot of procedural motions and things that happened, we moved this bill and had the governor sign it. It goes into effect July 1. That does remove this barrier of licensure and uncouples it from the Board of Medicine. I will tell you that there was a request for a fiscal note along the way, and it's very clear to stay germane to what the licensure was, which was a licensure bill, not what are the costs of nurse practitioners and nurse midwives in relationship to physicians in caring for the people in our state. And what that showed, the fiscal note that was requested as a blocking strategy, actually showed a $72,000 savings because of not having to do duplicate work between the Board of Nursing and the Board of Medicine. So that actually worked in our favor, and we moved it out of the House of Representatives and the entire legislature with only 6 no votes. So I was proud to be a part of it. It was a large collaborative effort, and if you move forward in this in other states in the country, I would really encourage you to find as many collaborating partners to support you, even strange bedfellows. One group we approached, we had 19 different formal groups. As you can imagine, all of the health groups such as AARP and other kinds of folks that would be interested in having access to care. But also we had groups come on board such as the South Dakota Municipal League, when we talked about what happens to the health of their community if you lose your primary access to health care. So at the end of the day, we were thrilled to be so successful in such a collaborative way. And I'll turn it over to the next speaker.
Great. Thank you, Senator Soholt. Our next speaker is Andy Baker-White, Senior Director for State Health Policy at the Association of State and Territorial Health Officials. As a member of ASTHO's State Health Policy team, Andy provides research, analysis, and legal technical assistance on public health issues. He also provides state legislative tracking to identify emerging issues impacting public health and state health agencies, as well as supporting peer networks for state health agency legal counsel and legislative liaisons. He received his law degree from the University of Kentucky College of Law and his Master's of Public Health at the University of Washington School of Public Health through the Community-Oriented Public Health Practice Program. Andy, I'll turn it over to you.
All right, thanks, Sydney, and thanks everyone for joining us today. So my topic today is I'm just going to give a really brief overview of some of the legislation that was enacted across the states and in the 3 practice areas that we're tracking or that we're using the website to look at, and then also talk a little bit about how this website and the issue of scope of practice is important to public health practice. So a little bit about ASTHO. ASTHO is a nonprofit organization representing the state and territorial public health agencies across the United States, and our vision is healthy people thriving in a nation free of preventable illness and injury. And just a quick overview of our membership: it's all 50 states, territories, our freely associated states, as well as the District of Columbia. So again, looking at the state legislation from 2017 for these practice areas, dental hygienists and dental therapists, physician's assistants, and nurse practitioners. To put this presentation together, I actually used our scope of practice policy website. The legislative tracker that Sydney, or the legislative search tool that Sydney showed you earlier is what I used. It's, searched each of the categories, looked at what has been enacted so far, and actually I also took a peek at what has made it through the second house of each legislature. And so, using that information, I was able to put together information showing, kind of so far, this is what's happened in 2017 in these 3 areas. So I've put together a map here that you can see, showing you the bills that have been enacted in the various states. A couple states actually bills in a couple of the areas were passed this year. So the first area, a quick overview of some of the things that are new in the states this year for dental hygienists and therapists. Colorado has added the ability for dental hygienists to administer emergency drugs and reversal agents unsupervised, but still in collaboration with the dentist. Nebraska has authorized an expanded function dental hygienist role, which allows certain permitted dental hygienists to assess the, let me find that here. Oh, so under indirect supervision, they can perform certain restorative functions. So again, they've kind of expanded the role of certain dental hygienists in Nebraska. In Georgia, there's a bill kind of dealing with supervision in different settings for dental hygienists. And in Iowa, dental hygienists will now be allowed to provide certain educational services unsupervised. Actually, that bill actually clarified what some of those educational services would be. And also in Washington, Washington legislature passed a law this year, and the governor signed it, that would allow creation of a dental health aid therapist in certain tribal settings. For physician assistants, this year, what we've seen so far in New Mexico, they now are going to allow physician assistants to either practice under a physician supervision or in collaboration with a physician. In Utah, there was a removal of a co-signature requirement for Schedule II and Schedule III controlled substances. And in Georgia, physician assistants were given the authority to prescribe hydrocodone compounds, but in a limited manner. There's a limited dosage limitations. There's dosage limitations and a couple other limitations on that prescribing authority. And also in Arkansas, there was an expansion of some signature authority by both physician assistants and nurse practitioners. And finally, in West Virginia, just kind of note, there was actually a bill that passed the legislature that would allow physicians assistants to collaborate with physicians. However, the governor vetoed that bill. And then finally, for nurse practitioners, we had the bill that Senator Soholt just spoke about the licensure issues. In Arkansas, again, the signature authority. And in Georgia, there was a bill that passed and that the governor signed that increases the number of nurse practitioners that a physician can enter into a protocol agreement with. However, that's only under certain circumstances and in certain settings. So real quickly, I just want to talk a little bit about, kind of how is scope of practice important to public health, and how can public health use this website to help their work. So this next map that I'm showing you is showing you all the states where the state health agency actually provides oversight of health professions. So it's about a quarter of our members here at ASTO who have the role and responsibility of providing oversight for these health professions. So this is a website that people working, that are public health practitioners working in those agencies can be able to use to see kind of what other states are doing, those trends, and so forth as they continue to provide oversight. Kind of also just some areas in public health right now that are kind of hot and of interest, really, that scope of practice really ties into. It can be the prescribing of opioids as well as the prescribing of opioid antagonists, expanding the scope of practice to nurse practitioners for those drugs. Supervision requirements in rural settings is something that is going to be of interest to public health. Modifying anytime there's an emergency response, issues of modifying the scope of practice so that the response to those emergencies are more efficient and easier. I've actually been seeing a little bit about in the states that have been adopting medical marijuana, allowing nurse practitioners to actually certify patients for the use of medical marijuana. So that's another issue with the medical marijuana that we're keeping an eye on. And then also the issue of just having maybe loosen dental hygienist requirements in public health settings. And so finally, the last thing I want to talk about as far as public health and scope of practice and how this website can be used is in the area of legal epidemiology, which is the study of laws, and it can be the study of laws and their actual impact on the causes of disease and improvement of health, and as well as policy surveillance as far as like kind of the comparative laws, you know, what are the states doing across the country on an issue. This is something that here at ASTO that we get questions on all the time from our members. When one state is considering doing something, they want to know what all the other states are doing. So this is a really good website that can be used to kind of see in these areas the different ways states are addressing the issues. So that was pretty quick, but I want to keep us as close to on time as I can. So there is my contact information if you have any questions or comments later. So Sydney, I'll turn it back to you. Thanks.
Great, thank you, Andy. Our next presenters are Denny Wood-Mancy and Christine Engstrom from the Department of Veterans Affairs. Denny Wood-Mancy serves as the Director of Physician Assistant Services for the VA and is responsible for all issues related to the recruitment, retention, credentialing, and utilization and education of physician assistants. As a member of VA's senior leadership team, he collaborates with other VA offices in the development of policy and guidelines to expand the role of PAs in the department's healthcare delivery model. Dr. Christine Engstrom is the Director of Clinical Practice in the Office of Nursing Service at the Veterans Health Administration, and she is also a practicing nurse practitioner at the Baltimore VA. Denny, I'll turn it over to you.
Thank you for that introduction, and thank you for the opportunity to present here today. I'm going to briefly go through changes in scope of practice and sort of the context in which they were established to try and keep us on time here. So as you know, the Veteran Health Administration is a national integrated healthcare system with 150 hospitals and over 1,000 community-based outpatient clinics across the nation in Guam, Puerto Rico, and the Philippines. So the need for consistent standards and scope of practice and utilization is essential for the VA to function efficiently. And the variations in state practice laws and regulations and VA facilities that may be geographically located in an area where their patient population comes from multiple jurisdictions made it necessary for physician assistants to use federal authority for practice across the system. And unlike other healthcare providers, nursing in particular, which they are now transitioning soon over to federal authority as well. A bit of an overview. We're celebrating the profession's 50th year anniversary this year. March of 1967 was the first class of PAs of 3 Navy corpsmen at Duke University that spawned the profession. Originally, it was to provide providers to assist the primary care physician in rural and underserved areas. So things haven't really changed much in all those years. The curriculum and training was based on the medical model used as in the so-called fast-track physician training for World War II. This resulted in a generalist training that cuts across all disciplines, which gives the PA profession its hallmark flexibility in being the only healthcare professional that can cross into and change different specialties without returning for formalized training. Changes in the scope of practice. Originally, the role and function, the scope of practice follows the function and role that the PAs played. So originally, they were trained to function as physician extenders or agents of the physician. It was task-oriented. For example, a physician assistant was tasked to perform the physical examination and history of a patient, then would consult with the physician. They would together manage the patient with the physician, usually determining what course of action to take. And PAs, before the advent of licensure by states or enabling legislation, practice enabling legislation, they practice under the authority of the physician's license. This was in the early days. So as the profession matured and the training curriculum developed, PAs moved from bachelor's degree to master's degree, and now currently there are some programs that are opening up with a doctorate degree. So as the profession matured, then the role changed. So the PAs were then licensed and credentialed to practice medicine, with the caveat that they did so with a supervision or collaboration with a physician. They were responsible for the care of the patient they were assigned. Often PAs had their own panel or practice, as you will, for primary care. Definition of supervision was broadened so that it allowed PAs to become more autonomous and reduce the burden on physicians, and practice without an on-site physician. This has been the case for a number of years, where PAs are practicing in remote site with the physician located 150 miles away. There's one case where a PA was assigned in a humanitarian mission in Micronesia. The closest physician was in Hawaii with contact through radio telephone. Changes the current scope of practice in VA. PAs practice medicine in collaboration with a physician. Collaboration meaning that a physician is available for consultation, input, or assistance when needed and requested by the PA. PAs have different levels of autonomy that must be specified in their scope of practice. 3 categories: full, limited, and supervised. Full autonomy, which fits most practice areas and most PAs, is that the physician does not have a role in the day-to-day practice of the PA, and only when requested. That is primary care settings and most inpatient hospital settings. Limited scope of practice are those for newly graduated PAs who have no experience, or PAs that are practicing and performing invasive or high-risk procedures. Supervised category is reserved for PAs who are undergoing training in high-risk procedures in which proctorship is required. The PA scope of practice has a core and expanded scope of practice. The core is what is expected of all PAs who have graduated from an accredited training program and are certified by the National Commission for Certification of PA would be able to do. An expanded scope of practice is more procedural or specialty related that are not included in the core scope of practice. What's going for the future? As you'll hear about probably from my next speaker, is full practice authority. PAs, we are currently developing policy to move into full practice authority in VA. This would remove the requirement for a collaborating physician, but require that the PA consult or refer to another appropriate team member when needed. Clinical privileges would be based on the individual's training and education, experience, and technical expertise and clinical competency. I will defer questions, I guess, towards the end, but that concludes my presentation, and I will defer now to my colleague, Christine Enkren.
Great, thanks, Danny. Here. So I'm going to talk about the full practice authority for nurse practitioners, clinical nurse specialists, and clinical nurse midwives in VHA. We decided to do this. It's been quite a journey. It started in 2008 and did not really end. It's not ended really, but our final rule ended in 2017. So it has been a journey similar to what Senator Solholt talked about in South Dakota. Ours is a similar journey, but times, I guess, 23 other states. So it's we've come to this point in time, which is great. We're very excited. When we started this, we started the journey with a purpose to standardize the practice across VHA. So the practice would be the same no matter where we were. You know, if we practice in San Antonio, Texas, it would be no different if that NP moved to Philadelphia, Pennsylvania. So we wanted to decrease those barriers and to help with the access, as I mentioned, and to ensure continuity of care for those veterans, of course. We did it on the premise that 22 states, including the District of and the DC, already have full practice authority, as do the DoD and Indian Health Service. We tried to get information from Indian Health Service. They've had this practice. It took them 10 years to get full practice. So it didn't take us quite that long, but just about. So a similar type of journey, very parallels. Certainly we have, as Denny mentioned too, with PAs as well, there's a diversity of rules and different regulations between states. So this certainly decreases that variation. So to do this, we had to invoke federal supremacy, as Denny mentioned, alluded to a little bit as well. Certainly what this does for us too is it streamlines APRN credentialing. So there's one standard of practice across the entire VHA healthcare system. As you all know, currently each state practice act has to be critiqued and evaluated, which sometimes can lead to ineffective resource utilization across our big system in VHA. So at the beginning of all of this, what we did, we certainly had to get a formal opinion from the Office of General Counsel, which we did along our journey. We've met with them many times along these several years. We also met with the National Councils of the State Board of Nursing. We had to get a lot of buy-in from many, many people along the way, many visits with senators and House representatives from all over the United States, many, many letters, many meetings. It's been quite a journey, but it has been a worthwhile journey, of which we're very excited. So our summary of the final rule, that final rule went into place in January 13th of this year. So that authorized APRNs to practice to the full extent of their education and training without physician supervision in all areas of practice, with the exception of controlled substances. Controlled substances are up to the state, and that does not change. VHA has had a policy for APRNs since, I think it's been the late 90s, that NPs could prescribe all legend drugs. So that was standardized across the enterprise since the late 90s, making that, creating that, that standardization for NPs, at least for those prescription drugs. The controlled substances, it does not change. And I have to tell you that that has been somewhat of a problem as we start to, as Senator Soholt said, uncouple collaborative agreements or protocols from the licensure. It's quite a complex, I have to say, complex to do this, as we found out with many states. So, what is it and what isn't to do? One of the things we want to make sure that we state is that NPs, always, just like Denny stated, we continue to consult and refer to other healthcare providers according to patient needs to ensure safety and quality. That is always, and we'd like to stress that the same as Senator Soholt said, no one is independent. No one is an independent provider. We all work in a team and we all work with each other. And I think that's been very important for us to stress as we move along this journey. That word independent gets thrown in sometimes by our detractors quite a bit. So it takes a lot of educating to keep repeating the team model that VHA celebrates and has been for our veterans. So what we've had to do along the journey, since January 13th, we have started to engage with all of our states. We have had some of our veterans, our facilities, even though they've been in states that enjoy full practice authority, our facilities in those states were restricting NPs by their bylaws. So we thought it would be easier and to go with those facilities that wanted to jump on the bandwagon first. However, we've had 90 that wanted to jump on that bandwagon very quickly, but we have started with some of those green states to help them revise their bylaws to allow for nurse practitioners to be, now within the bylaws, they must be LIPs. That's what they're stated in bylaws in VHA. So we're helping those facilities to change their bylaws first. We're having many meetings, calls, site visits to help facilities. We have an implementation team moving forth and a plan to roll this out and how we're doing it, along with an evaluation plan as well. Because we know that all eyes really in the nation are looking at VHA and how we implement this full practice authority. And we only have one chance to make it right, and we want to make sure it is right, of course, in the most safe and efficacious manner possible. So what we have done, our Office of, it's actually our Medical Staff Affairs office in VHA just put out a new template for bylaws that include the APRNs as LIPs, so that our facilities had that template to move forth with to change those bylaws. We have also used or developed from other sources core privileges for nurse practitioners in primary care, and then supplemental privileges for those practitioners that work in specialty care as well. We have a website for FPA to help facilities as they move on this journey to change their bylaws and change from scope of practice to privileges in their facilities. Many things don't change. We have, certainly it's a Joint Commission regulation to have FPPE and OPPE, but sometimes we're reviewing that as well with sites. So our implementation, as we said, we started on January 13th. We're going full bore ahead. It will take a while to get all facilities on board, but we want to make sure we do it right. So thank you for the time for us to explain how we're moving forth with full practice authority. And certainly, Danny, we want to help you all as well. Anything that we can do, we certainly want to move all our professions forward to give great care and have great access to our veteran patients. So thank you.
Thank you so much, Denny and Christine. We'll now move into a question and answer period. Please enter your questions in the Q&A box on the bottom left-hand side of the screen, and I will ask our speakers to address them. So our first question is for Senator Sohl. How can the Scope of Practice website help legislators when looking at scope of practice policies?
Well, it's an incredibly helpful tool because, as has been demonstrated during this presentation, the multiple nuances from state to state that are so different. So to be able to have a strategy in relationship to changing statute in your own state by looking at those around you, where are your referral markets, and what's happening within licensure. And that was a very powerful piece for South Dakota in moving this forward, that the inability to recruit and to retain, because we were out of step with what was going on around us. It wouldn't have been as helpful to look at what's happening on the east or the west coast in relationship to South Dakota. So I think the fact that that's at your fingertips from that Scope of Practice website is just an amazing tool.
And another question, Senator Sohl, you're speaking of Senate Bill 61, correct?
Correct.
Okay, for Andy, for clarification purposes, are dental health aid therapists the same as dental assistants?
No, I think the dental therapists have a wider scope of practice than the dental assistants themselves. They're also being used in more of the underserved areas. They really started catching on with the program through the state of Alaska and the tribal communities up there. And I think there are only a few states now that have authorized dental therapists to allow them to perform a few more services in a dental hygienist and a dental assistant. But it's just, I guess, another layer of that mid-level oral health provider.
Senator Soholt, how did, you spoke a little bit about working with a coalition. How did you all balance the concerns for patient safety and getting access to care for your rural populations?
Well, paramount has been quality and access. So we wanted to make sure that the current nurse practitioners, we looked at data and multiple research studies that we were able to talk about the quality outcome in relationship to the practice of nurse practitioners and nurse midwives. And then we went to all of the different national organizations that have position statements based on quality outcome data. And we also have a long history of having nurse practitioners and nurse midwives in those areas and a lot of community success behind that, just in the goodwill that is established within the community. And then also what we know about in relationship to complaints that have come to the Board of Nursing or situations that have had to be investigated. We have a very open and transparent system for that, and the complaints can come from anywhere. And knowing how few and far between they are and then how judiciously they have been handled. So with all of that, the Department of Health then came on as a proponent of this legislation. That was one of our first stops when we were trying to decide to move forward. Would the Department of Health back this? Which then allowed the South Dakota Board of Nursing, who's under the Department of Health, to be able to be a proponent and testify. Also, because of the quality outcomes in our state, the South Dakota Board of Medicine remained neutral on this bill. Even though they were highly encouraged to be negative, they said we have absolutely no evidence and we make decisions based on evidence. So that was key to the success of our strategy. Now, I will say that moving forward, because the National Council of Boards of Nursing helped us by providing funding for us to have a lobbyist, which was also very helpful to the coalition work. And we are now looking at doing further grant funding to do outcome studies in relationship to this change in our state, so that if it comes into question in 2 or 3 years, we would have the data to show that that simply is not the case.
Other questions? All right. Well, I would like to take this time to thank all of our speakers, and thanks to NCSL as well as the Health Resources and Services Administration. And thanks to all of you out there for joining us today. This webinar has been recorded and will be made available on the NCSL website next week. And my contact information is on this final slide if you have any follow-up questions for me as well. And again, the slides are available for download at the top of this screen for all of our other participants' contact information. Thank you all so much.